Hi, I'm Dr. Minish Jain for Cancer Talks. Today we are discussing multiple myeloma. Multiple myeloma is a blood cancer which is incurable. This is relatively uncommon. Approximately less than a percent of people would be affected with this disease. Why it is important? Because this disease has some features associated with our lifestyle and some which are uncontrollable. We need to understand them. So if you look at it is age related, people who are aging beyond 35, they have a chance of getting this cancer. Generally it goes higher at age of 60 to 65. The second risk factor is men, they are more affected compared to female. Then obesity is another risk factor. Then people who have family history, they are at risk of this cancer. So if somebody in the family is affected, sibling, father, mother, then the chances of getting this cancer is higher. Then you have some disease called or a condition called MGUS, which is otherwise a benign condition. It's called monoclonal gammopathy of unknown significance. But people who have this MGUS are also at higher risk of getting multiple myeloma, and people who have smoldering myelomas or in between. So these are also or solitary plasmacytomas. These are also having a higher risk of getting this cancer. So what are this spectrum of diseases? These are all diseases starting in a bone marrow with plasma cell as the primary responsible cell. We all know that we make blood in the hollow part of bone from where the plasma cells are, which are the fighting cells or which are producing the antibodies for us. So these are the cells, whenever there is an infection, they produce antibodies or immunoglobulins. Now normally these immunoglobulins are helping us to fight the infection. But what happens in myeloma? These are abnormal plasma cells. So they make proteins, but these are abnormal proteins which are useless to body. They are not working for us. But because of the increased proteins, paraproteins or immunoglobulins or antibodies or M proteins, whatever we call them, they can clog our kidneys. So they can damage our kidneys and they are eating up our bones. They are also using up the area in the bone marrow. So they are not allowing the normal cells to function there. So the RBCs, the WBCs, the platelets, everything is affected, and the normal cell numbers would drop. The normal immunoglobulin or normal protein numbers would be less. The abnormal proteins will be high. The kidney bones will be affected, and that is how myeloma affects us. There are many treatment modalities available for this, and we'll discuss that. But I want you all to know that myeloma treatments are improving, the survivals are becoming better, and the quality of life of these patients are becoming better. Though this is not curable, this is controllable and people can live normal good life with this disease. So how does myeloma get diagnosed? First, let's understand what are the symptoms. How do you know it clinically? So if somebody has got bone pains, which are like in the ribs or in the spine, or having constipation because of hypercalcemia, or getting mental fogginess or confusion because of hypercalcemia, then there will be decreased appetite, there will be nausea, there will be frequent infections. Like they are 10 times more at risk of infection compared to normal people. There can be weight loss. This is all because of the bones being eaten up. And we all know that 60% of our weight comes from bones. So if you are getting excessive thrust, if you are getting weakness, fatigue, bumps, lumps, if you see your ribs or bones popping up, or you're getting severe pain, now this could be a feature of myeloma. What causes myeloma? We don't know. So there is no real known cause for myeloma. Myeloma per se is not that serious disease. So if you control complications of myeloma, you can control it for many years because it is a disease which will keep responding to your treatments. The problem is complications. Now, what are these complications? Frequent infections. You can have repeated pneumonias, repeated urinary tract infection, and this sepsis sometimes can be lethal. So, a person can die of infections. The other problem can be broken bones. The bones are so brittle sometimes in myeloma that you, while getting up from the bed or putting a bike on stand, there can be a fracture. The third complication, which can be serious and which actually can be serious on diagnosis, is the kidney failure. So, if creatinine is high, that can be because of either the proteins going and clogging the kidney or the calcium going up and blocking the kidney. So, it can be either of these things. But we need to understand, if a person remains with renal failure, he is at high risk for mortality or death in the first 100 days. The next complication which can be there is like the WBC is going low or the hemoglobin going low or platelets going low. Now, this is all because of the myeloma using up the marrow space. So, this can be the reason of death in most of the cases of myeloma. So, we have to be very, very vigilant. We have to be ahead of the infections. We have to be ahead of complications and manage them quickly. So, then myeloma is not that serious if you manage all these things. How do we diagnose this? To diagnose myeloma, we require certain blood tests. So, the first blood test we would do is a complete blood count or a hemogram, where we look at the WBC, the platelets, and the RBCs. The second blood tests which are important for us are creatinine, calcium. These are then we have albumin, then we have LDH. Now, how does they help us? Creatinine will tell us the kidney functions, and if the kidney functions are affected, we know that it is going to be a bad prognosis. Calcium, if it is high, you need to bring the calcium down. So, that is another important test. Albumin, this is a normal good protein, but this is decreased in myeloma because the abnormal proteins are up. LDH, it will tell you that the prognosis is bad if LDH is high. Then we do the urine test. The other thing what we do in test is skeletal survey. We do x-rays of this patient, and you may be doing CT scan, you may be doing PET scan, you may be doing MRI, depending upon what is the situation. So, this is how you can do all the tests. Once you have done this test, you will come to know whether a person has myeloma or not. Now, what is smoldering myeloma? Smoldering myeloma is something which is neither MGUS, neither myeloma. So, you have plasma cells between 10 and 60% in the bone marrow. You have an M band which is raised. You have benzones protein in urine, but you have normal blood counts. You have normal calcium. You have normal kidney function. You have no organ damage. You have no signs of amyloidosis. This is smoldering myeloma. Why smoldering myeloma is important? Because there are a lot of research going on that you can block smoldering myelomas from converting into multiple myeloma. Now, if you can do that, you can avoid a cancer from happening. So, this is a very classical example of a benign condition MGUS which cannot be controlled turning into multiple myeloma through smoldering myeloma. So, that is why smoldering myeloma becomes important. And what are the treatments? Treatments generally are based on few things. Like what we do is we first try to find out what is the age of patient. So, if patient is young, fit, organs are good, and there is no kidney damage, patient can withstand strong treatments, patient is eligible for bone marrow transplant, that is what we are looking at. So, once we have seen this, we generally would consider these patients who are for bone marrow transplant for combination therapies. These combination therapies are like targeted therapy, immunotherapy, chemotherapy, and sometimes corticosteroids. So we use this combination. What we do is, once we give this treatment for 16 weeks to 24 weeks and we put the patient in remission, we check their bone marrow again to see if all the bad cells are gone. We check the proteins, whether they have become flat. This M protein is like when you do a graph of serum protein electrophoresis, you see an M pattern. This M pattern is because of the abnormal spike. One spike is albumin, the second is the bad protein. So you see an M spike. So once you see this flattened out, then you go for collecting the good stem cells either through a machine on peripheral stem cells, what we say collection, or you can do a bone marrow aspiration and collection of stem cells. Once you have done this, you can take the patient up for transplant immediately, or you can delay the transplant up to relapse. Generally, young patients are also recommended a double transplant, which is called tandem transplant. So you do a transplant after the treatment immediately and one transplant after 6 to 8 months or within a year of the first transplant. So this tandem transplant helps reduce the risk of recurrence. As we all know, myeloma is called incurable cancer. It can come back anytime, any year of the life. Means you cannot say that after 10 years it won't fail. So it can fail anytime. But you need to be on a watch. You need to make sure that you've crossed enough years, and then you can say that, oh, now your body has taken over. If the patient is not going to be a candidate for bone marrow transplant, then what we do? We generally go ahead with same chemotherapy, targeted therapy, immunotherapy, steroids. So we use a combination depending upon fitness, mental, physical, economical, social, whatever fitness you call. We look at all these aspects. Then we decide what is the best treatment. And so we have to give some treatment after that also. If a patient has a myeloma which is not responding, now there are 16% of patients who would fail in the first year itself. 84% of patients would cross 1 year. So if your patient or anybody is not responding, then we generally re-challenge them with another type of treatment. We try to put them in remission. Once we put them in remission, we again look at whether they are eligible for transplant or not for transplant, and accordingly we treat these patients. Now, there are certain new things which are happening in multiple myeloma. So, beyond targeted therapies, beyond immunotherapies, beyond steroids, beyond chemotherapy, we have new therapies called CAR T cell therapies. Basically, CAR means chimeric antigen receptor, genetically modified T cells. So, these are your own cells modified in lab, put back. The problem is two. One, that it requires a lot of money, and the second problem is it requires a few weeks for the T cells to be re-engineered in lab before they are given back. So these are two major drawbacks of this therapy right now. A lot of good development is happening for patients of myeloma. Even if somebody has no money and cannot afford all these treatments, don't worry. What you need to do, as I said, just take care of complications of myeloma. If you keep a person surviving out of complications, means if you just don't let them succumb to complications, they will survive very long. Thank you.